All right. Good morning, everyone, and welcome to the 15th Crisis Response Improvement Strategy Committee meeting. It's good to see all of you. Before we get started with our regular agenda, I'm just going to go through some slides that many of you are very familiar with, just to remind everyone how to use the Zoom technology. And as a reminder, I am Jamie Strauss-Clark. I'm your facilitator. All right, there are two slides. The first one is for CRIS committee members, and the second one is for our community members and guests joining us today. So CRIS committee members, please keep your mics on mute unless you're speaking. That will just help us avoid talking over each other. If it's available to you, please keep your video cameras on, particularly during the discussion portion of our agenda, which we'll be starting around 12:45 p.m. today. That just makes it easier for us to collaborate as if we were in a room together. Skip ahead, please. If you want to make a comment or ask a question, I'm going to ask you to use that raise your hand function. Click on the reactions button, pops up a window, and you can click on raise your hand, and I'll call on you in the order in which I see your hands up. Click ahead, please. If you would prefer to provide a question or comment via written form, please send it to me, Jamie Strauss-Clark, in the chat, and I will monitor the chat and occasionally pause between spoken questions and comments to review comments in the chat. Also note, if I see something in the chat and I'm not quite sure what is meant, I might chat you back and ask for a little more clarification before I read the comment. So you might see something back from me, and there might be a little delay as I make time to write in the chat as I'm facilitating. So please bear with me there. Click ahead, please. If you would like to see more CRIS committee members on your screen as we're discussing, please click on speaker view and change it to gallery, and that will put more folks on the screen. Please click ahead. All right. It's a very similar slide for our members of the public and guests today. Again, please keep your mics on mute throughout the meeting. Unless you sign up to do public comment, I'll call your name at that point and you can unmute your mic. I'm also going to ask our members of the public to please keep your video cameras off throughout the meeting, with the exception of the end of the meeting. If you're going to make a public comment, I'll invite you to turn your video camera on at that time. Click ahead, please. Similar to my instructions for CRIS members, if you'd like to see more folks on your screen, just click on that speaker view button and change it to gallery, and you'll be able to see more people. And then regarding chat, I am not going to be able to review or respond to chat comments from members of the public. I'll need to stay focused on comments from CRIS committee members. However, if you would like to sign up to make public comment at the end of the meeting, please send a chat to Brittany Thompson, my colleague. She'll be monitoring that, and we will reserve 10 minutes at the end of the meeting for public comment. I'll take you as many folks as I can before we run out of time. Or if you're having any technical difficulties, please message Brittany Thompson and she will do her best to assist you, at least with anything that's within our control. Couple more housekeeping notes. Unfortunately, despite best efforts, we do not have ASL interpreters joining us today. So, and Brittany's going to put this in words in the chat as well. If you need any support today for understanding and following the meeting, please message Brittany and she will turn on the closed captioning. So again, if you need any support today, with understanding or following the meeting because you might have a hearing impairment, please message Brittany Thompson and she will turn on the closed captioning. And she put that message in the chat as well. One more piece of housekeeping before we move to our actual agenda. With the evolving changes in public meetings requirements, we are now offering a physical location for people to join by Zoom, to participate in this meeting by Zoom, in case you have limited access to internet or some other reason that you're not able to do Zoom from home or your office. And we'll be letting you know when we send out meeting invitations where that location is. Today, it's at the Pat Steele building at UW. I believe that was in the meeting invitation. Dr. Snowden is in a room with Zoom. So if anyone needed access to Zoom today, that's where he will be. We'll let you know in future ones. I also want to acknowledge that we are still very committed to finding an opportunity for us to convene in person. We're looking at September. That is different. That would actually be all of us convening in person with a remote option. We'll keep you posted on that. Okay, I think and then one last thing I'm going to ask CRIS members is when you speak today, if you wouldn't mind just as before you start speaking, remind everyone your name, organization, pronouns, anything that you would like folks to know before you speak. That'll just help remind us, particularly our community members, who you are. All right. I think that does it for the logistics here. So Chloe, if you could take down. Great. And I am actually going to turn it over to one of our wonderful CRIS committee members, Jessica Shook, to make some words of welcome. Jessica.
Thank you, Jamie. Hi, everyone. I am Jessica Shook, and I originally come to this committee because of my role on the executive committee for the Washington Association of Designated Crisis Responders. But I'm also a crisis worker, and I'm a clinical manager of a crisis team. On my crisis team, we had a rough week last week and a rough weekend over the weekend. A lot of people in our community were having a really hard time. We are struggling, like so many crisis providers and behavioral health providers across the state, with staffing and resources, places to refer people to, and ways to get them there. And when I was asked to offer the welcoming remarks last week, I was reflecting back on the work of this committee. And in parallel, I was reflecting on the work that we do, that my team does every day, providing crisis work. And I thought about the deep dive we've taken in this committee and in the subcommittees onto so many aspects of this work that are so important, but historically, they are rarely talked about as part of one huge system. All of us within this system, people who are receiving services, people who are providing services, people who are advocating for the provision of services, a lot of times we start to feel so stuck, like we are the only ones who are experiencing what we're experiencing, but we really are part of one large system. And the issues that we face need to be tackled as part of a large system. Like doing crisis work, caring for a loved one, or living in the world with lived experience, this work feels endless, because it is endless, and it should be endless. We always benefit from communication and the perspective of others, especially when that perspective is personal or is radically different from our own. Especially for the professionals in behavioral health work, it is much, much, much easier to simply put our heads down and move through referrals, trying to get to each person in need as soon as possible, because there are always plenty of referrals stacking up. We get caught up in the challenges and the roadblocks. And as a result of that, we do lose track of the big picture. It's very easy to lose track of the big picture. And we lose track of the overall goal of the crisis system, which is to support individuals in a way that supports their safety, but also their dignity and their autonomy. And all three of those things are incredibly important. Historically, designated crisis responders in particular have held themselves outside the crisis system, seeing their role as distinct, confrontational, and set apart. And those things are true, but they're not completely true. When I was coming up in my professional community, it was very common for DCRs, then DMHPs, to say that no one understood us and to kind of moan about this lack of understanding of the barriers and the challenges in the system in doing our own particular slice of crisis work. Well, of course they didn't understand us, because we actively, at that time, historically, were avoiding understanding. And if you don't change the way that you're interacting with others, others are not going to change the way they're interacting with you. And you're also not going to be able to benefit from those other perspectives and those other pieces of information. For that reason, and for many other reasons, I'm glad to be here participating today in this committee and in all of these conversations. I'm glad to be in leadership in the community of crisis workers, and I'm grateful to be here with all of you. Thank you.
Jessica, thank you so much for that, and especially given how challenging your week was last week when you were preparing for this. So it is much appreciated. And they are very appropriate words for our conversations today. With that, I'd like to take everyone through our agenda and objectives for today's meeting. So Chloe, if you wouldn't mind putting up the slides back on the screen, please. All right, so our objectives for today, and some of them will look familiar, you've seen them before. We're going to start by reminding ourselves where we've been, where we are now, and where we're going in this CRIS process. Today, we're going to hear updates, not just from state agencies and the governor's office, but also a couple of CRIS members have some updates for us relevant to 988 and the behavioral health crisis response system improvements. We will get to hear outcomes from the first responder and behavioral health crisis response collaboration work group. And then the bulk of our meeting will focus on discussing recommendations for addressing system gaps related to someone to come, specifically mobile crisis response. We'll confirm action items and next steps and hear public comment. So if you advance the slide, please, Chloe, I'll just give everybody the timing and all this. All right, so we're in our welcome right now. We're going to move into our personal stories shortly. And then after that, we're going to have our system updates and agency Q&A. You did get that newsletter, and so this will be an opportunity to ask some questions, but also, as I said, hear from some of our CRIS members on some big updates. Then you'll hear at noon, you'll hear a presentation on the outcomes from the first responder and behavioral health crisis response collaboration work group. We'll aim for a break at 12:40 and come back together at 12:45 to launch into our discussion. This will be the first of some continuing discussions, and Betsy will go through the cadence of this momentarily on exploring potential recommendations to address system gaps for mobile crisis response. We'll go to action items and next steps at 1:45, and then at 1:48, public comment, and adjourn at 2 p.m. Advance the slide, please. Okay, I'm going to turn it over to Betsy, who's just going to remind everyone where we've been, where we are, and where we're going. Betsy.
Thanks, Jamie. Hi, good morning, everyone. I'm Betsy Jones with Health Management Associates. I'm leading the charge to facilitate and work with all of the folks behind the scenes to make this process happen. So today we're talking about a synthesis of recommendations relating to someone to come, including the work that we'll hear about from the collaboration between our first responders and behavioral health crisis providers work group. We have done some work already on someone to come in March and April. And so what we're doing today is really bringing those, the beginning conversations forward to get to more of a synthesis of recommendations that will help us then continue in August with recommendations, not only for somewhere to come, but a place to go as we continue down the path of recommendations relating to services this year. That's really been our focus. In August, we'll also hear an update on the 988 Contact Hub rulemaking from our friends at DOH. The next slide, please. And that will assist us in drafting some recommendations, getting to more formalized recommendations in September. And that's when we're hoping to have an in-person meeting. In October, we will take a break because we, HMA, will be drafting the report that we'll be submitting in December. In November, we'll be reviewing that draft report and really taking time to make sure that all of our CRIS members are on board and feeling good about the report that we will be submitting to the legislature and the governor's office at the end of, well, I guess January 1st. And I'll pause there.
Thanks, Betsy. So as Betsy said, in our discussion today, and we'll set this up a little bit more, we're going to be building on the work that you all did earlier this year at our February, March, and April meetings, identifying gaps in the mobile crisis response systems for adults and the mobile response and stabilization system for youth. We're actually going to revisit those and start talking about, given the progress that's made to date, what other gaps, what are some ways we can continue to fill those gaps, and what are some things that CRIS can continue to do. So that's what we'll be talking about later today. Thanks for presenting all that, Betsy. Chloe, would you mind taking the slides down? Thank you. Just want to mention, last month after the June meeting, we sent out a survey to CRIS committee members to provide us with feedback on how the meeting went. And we got responses from 7 CRIS committee members. Thank you so much for that. It actually is very, very helpful as we think about how we can continue to improve and strengthen our collaboration together, particularly given that we do so much of this in a virtual space and not a together space. Physically together space. So we're going to be sending out another survey today, and I do encourage CRIS members to please take a few minutes to respond. As I said, it does really help us. We're going through the responses from the survey from last month and already thinking about some changes we can make or some improvements we can make to how we facilitate these meetings and how we engage you all. So we'd love to hear more from you. Again, please look out for that survey at the end of the meeting today. Last thing on the public comment process, I'm reserving the last 10 minutes of this meeting for public comment. As of now, I have no one signed up to make comment today, but community members, if you are listening to the meeting today and you think you would like to make a public comment, please send a chat to Brittany Thompson. I will take as many people in the order in which you send a chat to Brittany as I can in those 10 minutes. Just a few reminders of how we do this. Typically, the comments are limited to 2 minutes per person, so we can get as many folks in as possible. If I see a longer list, I might shorten that time to 90 seconds, and I will have a clock to measure time. If you are someone who might need a little extra time to make your comment, please do let Brittany know that you need an accommodation in your chat so that we can plan for it. It would really help if you set that chat sooner rather than later, just so we can plan for the end of the meeting. And finally, just a reminder that our CRIS committee members will not be responding to your comments. This is a time for them to listen to you. So hopefully that gives you a good overview of how the public comment will work. And now I am going to turn it over to Bipasha Mukherjee, who's going to introduce our personal story today. Bipasha.
Hello, everybody. My name is Bipasha, as Jamie said. She, they, and I serve as a person with lived experience on the CRIS and steering committee. We, the Lived Experience Subcommittee of the CRIS, have started working with Washington Speaks. Can I have that slide up, please? Thank you. Okay, we started working with Washington Speaks, through whom our speaker today, Heather Sturdivant, comes to us. We were introduced to Washington Speaks by HCA, thanks Carrie Waddland and Dakota Steele. The organization, Washington Speaks, is contracted by HCA to nurture the stories of people with behavioral health lived experience and have them speak at events and meetings such as this, so their lived experience can be harnessed to help agencies and organizations build stronger and more equitable systems and services. Next slide, please. Thank you. Heather is a native Washingtonian, born, raised, and still living in Olympia, Washington. She grew up in a family of bikers and hippies. They were loving, but they also had a lot of traumas which were passed down. Her professional arc, and these are her words that I got permission to quote, "I'm a peer counselor who used to be a drug dealer." She will be 14 years sober on July 27th this year. Today, she works as a peer case manager, recovery navigator at OHRS, which is Olympic Health and Recovery Services, on the Thurston LEAD, which stands for Law Enforcement Assisted Division team. She's speaking today, though, in her own capacity and not as a representative of OHRS. Her favorite show is Chicago Fire. She especially loves Chief Bowden in the show because he builds a wonderful family out of Firehouse 59 by being loving, kind, empathic, and supportive and compassionate in his approach. A model I know all of us lived experience folks would love to see in first responder teams because it will translate to how we get served. Heather used to think she was a social introvert, but as she has healed, she has realized she's a full-blown extrovert, happy, transparent, and honest person who loves to talk to people. When she was younger, a librarian called her a sourpuss, and now her colleagues call her Bubbles, highlighting to me that self-discovery with proper care and support for behavioral health issues can be a wonderful journey. Folks, here is Heather Sturdivant. Next slide, please.
Hello, so I'm Heather Sturdivant and I use she, her pronouns. And I am a person with a lived experience for sure. And I'm here today to talk about mobile crisis. And so I'm just feeling a little anxious, just to put that out there. Little anxious. Okay. So yeah. So I was born and raised here in Olympia. And like what Parsha said is that, you know, I grew up with a family full of love, but as well as drugs and alcohol and bikers and hippies. Yeah. And so just my own little personal system failure was that when I first got clean and sober, you know, I just had 3 emotions, and they were anxiety, panic, and depression. And I was told, just get sober, it'll be okay. And it was not. And, you know, I was reaching out to try to get help with the mental health stuff that I didn't know that I had until I got sober. And so the system was, the failure was part of my relapse. Because I did relapse, and then then finally I was given the opportunity to get some mental health help. And so my personal experience is that you know, my whole entire life I spent trying not to feel feelings. I did really good at that because I always had drugs and alcohol to help. And so when I got clean and sober, and of course for the first 5 years, it was just panic, anxiety, and depression. And it was a lot of panic and a lot of anxiety, and I didn't have any coping skills on how to deal with it. And my best friend, she was like, well, let's go over here to Capital Recovery. And I was like, well, is it free? And she's like, yeah. And she says, well, does it have food? I asked her, does it have food? And she says, yeah. And I said, well, count me in. And we went over to Capital Recovery, and I started receiving peer services. And, you know, because at that point I had been suicidal every single day for 2 years. And it was really hard. It was really hard because I didn't have any way of coping with, you know, the overwhelming feelings of panic and anxiety. And I wasn't equipped. I just didn't know how to do it. And so I was over, and my mentor, she asked me, you know, well, do you want to do this training? And I was like, well, okay. And, you know, once again, I asked the question, is it free? You know, did they have food? And she's like, yep. And I was like, okay. And so I took the certified peer counseling training, and that was 9 years ago. That was 9 years ago. And I was at that point finally given a solution on how to cope with all of, you know, the feelings that I was having. And I was finally given a purpose. I was finally given a place where I was supposed to be in this community. And it completely changed my life. It completely changed everything in my life. And so, next slide, please. The reason, oh, I guess we missed the fire slide. Back a slide, please. There we go. So yeah, my life was really on fire. And I didn't know how to not have my hair on fire. You know, okay, now we can do next slide. And you know, I was reaching out and reaching out and reaching out, and I just wasn't getting what I needed until I was able to go over and get into peer counseling. And so what I have built, you know, for myself along the way is the coping skills. And so I took the training, and I was doing some internship and stuff, and I got hired on, and for the first time in my life of having a job other than dealing drugs, I was given an income and a purpose and a solution to all of the panic, anxiety, and depression. And so my thinking is what would be better is if I would have been I suppose if I would have, I don't really know what would have been better. I just want to talk about what was helpful, I guess. So I'm just going to skip that one. And next slide, please. So, you know, I built for myself a safety net, and I built myself a safety net because I knew that I would fall down a lot, and I did. I fell down a whole lot, especially during crisis, and and I was told, you know, people bet on me that I wouldn't stay sober after my first relapse. They bet that I wouldn't stay sober because I was such a train wreck, because I didn't know how to cope with the anxiety, depression, and panic. And so next slide, please. So I was given a safety net by asking all of these different pieces to be there for me. And of course, you know, my dentist is on there because, you know, these are my teeth, and I did do meth for 24 years. And so I happily have my orthodontist and dentist on this safety net. And, you know, my bosses, my coworkers, who I have a coworker here with me now who's supporting me, and my family, my friends, you know, I have a sponsor because I am a member of a sober support group. I have my psych med provider. I also have a counselor and a therapist. And I have all these pieces that I need, because when I did fall, I asked for help, and I was able to have my best friend come and get me when I was, you know, my last crisis. She came and got me, and we went to urgent care because that's where I was told to go. I went to urgent care, and now I'm friends with one of the security guards at my healthcare place, because he sat with us for 3 hours. And, you know, I was given what I needed when I fell down. And so the piece that's missing that I see for many, many, many people that are in our community is after the stabilization, after the hospitalization. They just kind of get sent back to wherever they came from, whether that's the streets or their home, and they're not really given peer support. They're not really given a case manager. They're not really given someone to help them with simple stuff like checking the mail, making your appointments, getting your medications. You know, do you need to go learn to ride the bus so that you can go grocery shopping? You know, and this is a huge gap. that I feel that is missing for the folks, you know, in our community that experience crisis. Because it seems to go just from crisis to crisis to crisis. There's actually the gap in the middle is the piece that I really feel that if we as in taxpayers, if we put money into providing like peer services to folks that have high acute mental health, that have a lot of crisis, that are, you know, often unstable. If we were able to give them someone to walk beside them, and one of my SUDPs says that about me to my clients when we talk, he always says, Heather is going to walk beside you. If we had that for folks, I think the crisis would be less. I think the hospitalizations would be less. And I think we wouldn't need as much stabilization because they would be able to call, like the client that called a minute ago that I knew needs to talk to me, but, you know, I can talk to them in a few minutes, but, you know, it's because I get to walk beside people in my life today. And just to wrap it up is that, next slide, please. When I was at Recovery Advocacy Day, and that's the pink sweatshirt picture, I was there with Ricky, and I was there. He walked me to the Capitol, the very first Recovery Advocacy Day. He walked me to the Capitol building. And then just this last year, he was at Recovery Advocacy Day, and I was talking him up and introducing him to another friend of mine. And what I didn't recognize was the red flags, because he then a month later overdosed and didn't make it. And so I really feel like that my work that I do here on the planet, my purpose is to be available for people, people that need peer counseling, people that need someone to walk beside them. And, you know, I am an addict and an alcoholic, and I am in long-term recovery. And, you know, I just love that I get to live my life today and just be of maximum service to help other folks, whether that's in the mental health field, whether it's in the SUD field. But I'm just incredibly grateful. And I just want to, I'll end on this, is that Chief Bowden on Chicago Fire, I am in love with because of the person that he is. He's wonderful. He loves everyone, and he helps empower people and build their lives into something that is so meaningful and so helpful and so amazing. And so that's why I love Chicago Fire so much. And so with that, I'll go ahead and close, and thank you all for listening.
Thank you so much, Heather. I appreciate your vulnerability here today, sharing your story. It was very beautiful. I love hearing you say that your purpose is to walk alongside others. And I'm very sorry for the loss of your friend, but I commend you on all the hard work that you've done. And I appreciate you sharing the story with us. I think a lot can be unearthed from what you shared, healed and learned. And I appreciate you, we all do. And so I just want to just extend my gratitude for all the hard work that you've done to build yourself up and the work you do out in our community. I'm going to go ahead and hand it over to Jamie.
Thank you, Marie. Oh, Heather, that was beautiful and raw and so meaningful to us. And I just keep thinking, I was reflecting on that circle you showed and how you created your safety net. And everyone here, we're all working so hard to make it possible for every person who needs it to create that safety net and then land in it when they fall. So Heather, thank you so much. And I am also so sorry for your loss. And I'm so glad you have those beautiful memories to remember. And thank you. Thank you for being here, and thank you for getting through the jitters at the beginning. I know how that goes, so I appreciate it so much. And with that, let's move into our system updates and Q&A. We did send out a newsletter to CRIS committee members with updates from agencies on the most recent development since we all got together in June. So you heard from the governor's office, from HCA and DOH, showing progress. And I also, before we go into the Q&A that you might have for our agencies, I also have a couple of CRIS committee members who have some updates to share. So we're going to be hearing from Claudia about an update at CMAR, and we'll be hearing from Michelle at Crisis Connections about call center co-location. So Claudia, if I can kick it over to you, you can maybe get us started.
Sure, thank you. I'm Claudia Dialegre, Chief of Behavioral Health for CMAR Community Health Centers, and also the representative for underserved and BIPOC communities. We, as part of the governor budget, we've received some funds and a lot of the support and help from Representative Orwell to create a crisis center. We had in the past received some funding to do a detox facility. We just put a little bit of this in perspective. One of the plans that we have is really to create a youth village where we will be able to house different services in one. So we currently have a location where we have an inpatient residential facility for youth, 16 beds. We also have a recovery house where we have a 12 beds. It's just co-located. And these 12 beds are supposed to be a step down from the inpatient facility, also receiving people from the community. The plan is to have in the same location, as we call in the village, in the first floor, to have this crisis receiving center, but at the same time, they can be a no run door access. So they could be a detox in the sense of if it's somebody who have come with a mental health crisis is admitted, if it comes with substance abuse crisis would also be admitted. This is just a preliminary draft that we have in terms of how the facility, this first floor is looking like. Some of came from our visit. We have some of us who went to Arizona and look a little bit about crisis center. But our plan right now is to, right now we have a design possibility like a draft. We are going to work with a youth group that we are hoping to receive feedback and some things that maybe we're not seeing, they will have to be there. And then after that, we're going into permit review, submission of permits to the city and the state. So we're thinking that construction might start this year, probably at the beginning of the year of 2024. We probably take a year to develop this. As you see, it's a share between detox and crisis center. The idea that we have has a nurse station that's able to provide oversight for both of the sides, have a lobby area with exam rooms for people who are admitted, a big recreation area for a youth, place where they can have activities, do different things, and an outdoor activity area who is enclosed, but they has a big open space. We have created 2 separate areas for dining, either for people who come from the crisis center or people who come from the detox that also have their own space. Detoxing from substance abuse to me is different than a crisis of mental health. So creating that space where people will have them. I mean, if I'm feeling real sick because I'm detoxing, I have my privacy. If I also have a mental health crisis, that I have that space where I can maybe go into the outdoor area. So this is just a preliminary permit, preliminary draft of the way we think it should look. It will go to committees that we hope to bring the community to provide more feedback. But that is sort of where we are. We work in CMAR, has an architect firm that works, is part of CMAR. And our architect is working with us and is getting ready to submit the permit to the state and to the county as soon as we get more feedback and finalize this. So this is sort of where we are right now.
Thank you, Claudia. And I'm going to open it up for questions from the CRIS committee member in just a moment. I'm first going to ask Michelle McDaniel with Crisis Connections to update us on co-location, and then we'll go into Q&A. Michelle?
Great. Hi, good morning, everyone. Michelle McDaniel, she, her pronouns. I'm the CEO of Crisis Connections. And of course, we're one of the 398 Crisis Center hubs. So I'm going to speak specifically about co-location, 911, 98 co-location activities planning from our organization, but I'll also touch a little bit on the higher level since we work very closely and collaboratively with Frontier and VOA and really developing all of this work, and just really appreciate their partnership as we work together for a statewide response. So first and foremost, we're all in beginning year 2 of our contract with DOH to provide the 988 line services. And so that includes some great expansion, making sure that we are covering each other as in-state backups, that we're expanding the text and chat function, and then as well as start launching 988 911 co-location in various PSAPs around the state. So Crisis Connections has been in conversation with one of the PSAPs in our region. Again, Crisis Connections is responsible for answering calls that come from area codes from the King County region. And so we've been in communication with Valleycom and planning for well over 18 months to develop a co-location system, one that we can actually scale up and down as needed to based on call volume. And again, the idea is to be able to have more immediate access to supporting 911 operators in their work, getting callers more quickly to the 988 service when that's more appropriate. But also, again, supporting 911 operators and being able to help identify when a handoff to 988 is appropriate. So, like I mentioned, Valleycom is the organization we've been primarily working with. We also have been in communication as well with Seattle 911, so that when we're ready to actually launch this, we are be able to co-locate within those two. Co-location ideally will be statewide, but not in every single 911 PSAP. Really, we're focusing on the kind of higher volume ones. There was some media, I think, a week or 2 ago that our friends over at VOA are actually launching part of this pilot with a PSAP in Pierce County. So you may have seen some promotion of that and some great media on that. So understanding from DOH, and I don't want to speak for Michelle Roberts and team, but what we also want to be able to do is be very thoughtful and working together across the state to make sure that we're not moving too fast. As you can imagine, co-location within 911 and the idea of partnership, particularly with law enforcement, has some concerns with it from the public. So we want to make sure that as a state, we're vetting that, bringing in the public and making sure that we're getting that input. The idea here, again, is to make sure that we are supporting the public so that first responders, who we generally have become dependent on for behavioral health crisis response, we're stepping away from that dependency and bringing in the behavioral health resource as quickly as possible. And again, a couple of quick things. There's things to think about that are very logistically important. We're currently at Crisis Connections vetting a memorandum of understanding based on the Vibrant guidelines, as well as vetting some data sharing agreements, making sure that this is all done in a way that's protecting HIPAA, following all of the state guidelines and of course national guidelines around this work. So again, tremendous partnership that has been happening within Crisis Connections with our local partners, as well as across the state, and shouting out as well to Adam Wasserman from 911 for helping us out in all this work.
Thank you so much, Michelle and Claudia. Really appreciate the updates, and that's exciting stuff. I'd like to offer opportunity for our CRIS committee members to ask questions of you. Also, Carrie Waterland, Michelle Roberts, and Megan Celedonia are here if you have questions on anything you read in the newsletter. So if questions, please raise your hand, CRIS committee members, or send me a chat.
Maybe while we get a question, this is Claudia, just I forgot to add up toward my report, we have been working or just meeting with a partnership with Children's Hospital. I want to say Kashi had been really helpful in trying to bring her team together too. We have been meeting in different times and want to continue this partnership to help us to look at things in a bigger picture. So I just wanted to do that call out. It has been helpful. We really hope to continue in that relationship.
Thank you so much for adding that, Claudia. It is always really good to hear about these partnerships and collaborations. I see hands from Representative Orwell and Kashi. So Representative Orwell.
Yeah, I want to say thank you. I know everyone's working so hard to get these things up and running, and that's really a challenging part of the implementation, but it's so exciting. Having gone to one of or both of two of the three sites, 911, they have tough jobs, and, having that partnership with 988 is going to be so important for the system. So I just want to say thank you. I know there's a lot of detail. The other shout out to CMAR is that we've had this youth group, including youth focus groups in the schools, that really have been driving this process. And I just really want to thank Claudia and your agency and Children's and everyone who's really been part of convening the voices of youth as you create this. It's really great work. Thank you.
Thanks, Representative Orwell. Kashi.
Hi, Kashi Arora, she, her pronouns. I work at Seattle Children's and I sit on this committee as the Child and Youth Behavioral Health Representative. I have two questions about updates. Michelle, your description of co-location was really helpful when I read it in the newsletter. I wondered what impact that would have on the response people might get. And so hearing your description gives me a clearer picture that it sounds like co-locating 911 and 988 means that actually we would expect more calls to get triaged to 988 and less to go to 911. I heard you use the word media. I'm wondering if you know, or if others know, if there's a comms plan around how to share that with our community. I imagine that hearing 911 and 988 are co-locating is going to raise concerns, like you mentioned, Michelle. And I'm wondering if there's a way for people to walk away with the same understanding that I'm walking away with right now. And I have one quick question about what's in the newsletter too.
I have not personally been in conversation about communication, so I'll punt that over potentially to Michelle Roberts or others at DOH around that part.
Yeah, I think we're working to do this. It is a pilot phase and kind of beginning of planning around co-location. I know both of the call centers are have been talking about it and talking about some of the PSAPs, but funding just started for this work July 1 for 1134. But yeah, we'll continue to work on and I can loop back with my team because I know we're interested in exact same consistent messaging and talking about this. So we can take that back, Kashi, and do some follow-up.
Thank you. And then my quick question about the newsletter is there's always a standing update about the 988 call volumes. And given some of the conversations we've had about how we can tell when youth are calling, I would just love to make a request that if we could get a breakdown of the number of youth callers that we know for sure are youth callers, that might give us a sense of how many not only youth are calling, but we might be able to at least educated guess reverse engineer how many youth we might be missing. Thanks.
Yeah, that's not super easy, but I'll talk, and it's not consistent. Yeah, but let me talk with the team and see. I think we talked about why that's not super easy in past meetings, and I'm happy to go into more details. Number one, because it's anonymous and we do not collect information that people do not want to disclose to us. Also, right now, part of our technology plan is moving towards a unified statewide platform. We don't have that now. So like, what are these indicators and the data points we want to be tracking consistently between the call centers? That's work that has a longer timeline as well. But let me talk with my team and the call centers about what may be possible there.
Thank you. And Claudia, super excited to hear about the crisis receiving center. Sorry, Jamie.
No, that's great. This is important. And I do have a question in the chat also from Dylan. Are we defining youth as under 18 or under 13 or some other age? Is that also a question to be answered?
I was just thinking if we're going to be collecting that type of data, well, just thinking of shared data definitions.
Yeah. Are there any data definitions, or is that something that's a little bit of a moving target for us? Does anyone have an answer to that? Carrie.
Hey, I will just say in kind of our world, in working with both federal and state government, youth is can go up to 25 when you include transition age youth in that definition. So I would say something to throw out to the CRIS group is if you want to, we can give definitions of youth, of transition age youth, if that would be helpful to folks as a starting point. And so that we don't have a bunch of definitions that are around. I think transition age youth is a pretty established age range. And I think 25 is a pretty established age range when we look at research for youth. And so I'd just lob it out there to say we could provide some definitions for people to react to. I'm going to wait and have Kashi tell me if I'm completely wrong, but all of our subject matter experts differentiate between youth and transition age youth, and that goes up to 25. Thank you, Kashi, for nodding.
I would agree with that. I think youth for me is under 18, and then transition age youth are 18 to 25, but I'm looking back at HCA to ask about MRSS, how old you can be to get an MRSS response for youth. And I wonder if that definition could be incorporated here, because the point of having the data on youth callers to 988 is to understand how many youth we should be connecting to the standard best practice, which is MRSS for youth. And so if MRSS can serve, I can't remember, Sherry's going to correct me if it's 21 or 25 for MRSS, but that would be my definition.
I love that, Kashi. And just really briefly to let everybody on this call know, we actually have a conversation this afternoon to talk about MRSS. So Sherry and team, who everybody's on the line, help me remember that we are going to kind of talk about the definitions and tie all of this together, as Kashi just said, as we speak this afternoon.
And I put this in the chat, but Sherry Wiley, Carrie's colleague at HCA, was on it. I missed an M in what I copied and pasted, but minors are 17 and under, transition age youth is 18 to 25, age of consent in Washington is 13 to 17, and then MRSS can go up to age 20 in alignment with, can someone help me out with this acronym, EPSDT?
Early prevention. It's well child visits for kids.
Okay, thank you.
Early periodic screening, diagnosis, and treatment, maybe.
There you go.
Oh, nice. Yes.
Yes.
Ding, ding, ding. Yes. Good job. That's exactly it. All right. I see a hand from Representative Orwell.
Thank you. I was going to see if Claudia might be willing to jump back in, because I think they're doing some really exciting work with dialectical behavioral therapy and versions that have been modified for communities of color. I don't know, Claudia, if you can say anything on that.
Yeah, we continue expanding this is the creation of dialectic behavioral. So dialectic behavioral health therapy is an evidence-based practice, but in places like South America had a very specific training they call the third wave evidence-based practice, where they are specifically developed for communities of color. We have one of the trainers. They had been developing all of this in Argentina. We were able to bring them to United States. We have now a cohort. We're training 20 providers who speak Spanish, who will be able to develop, maintain this evidence-based practice with the modifications for the Latino population. We also have contracted with some of the creators back in Argentina to continue doing fidelity and sustain the model. So we're very excited. This actually, we had received some funds to continue some of the can't pay for the contractors and some of this implementation. So we are very, very, very excited to maintain this DBT with the specific modifications for people of color or the Latino population. So yeah, we keep moving forward to just making that happen.
It's fascinating, Claudia. Thank you. And thanks for raising that, Representative Orwell. Any last questions? This has been great. Good fodder for discussion here. Any last questions from CRIS committee members? Just make sure I didn't miss anything in the chat. Oh, Levi mentions the 988 LGBTQI plus youth subnetwork includes up to 25. So I think echoing that framework we were just talking about for defining age. Thanks, Levi. Okay, we're a few minutes early, but I think all of our presenters are here. Michael, Puck, Bethany, are you all okay getting started about 5 minutes early? Let me know if you have any concerns. Oh, great. Thank you, Puck. All right. So this is the presentation you've all been waiting for. Outcomes from the first responder and behavioral health crisis response collaboration work group. And we have some members of that group who are going to present today. But first, I'm going to ask Michael Anderson-Nathy, who facilitated that group over the course of a couple of months, to cue things up and kick us off. So, Michael.
Yes. All right. Hello. Hopefully all can hear me. I'm sorry. I'm calling in from somewhere completely different. I'm overseas, and so hopefully my internet will stay stable. Yeah. So my name is Michael Anderson-Nathy. I use he, him, his pronouns, and I'm a member of the kind of HMA team helping to kind of facilitate. Like Jamie said, I helped with this work group, and I'm here with Puck and Bethany, 2 members of our work group, and we're going to present to you the outcomes from our behavioral health crisis response and first responders collaboration work group. Puck and Bethany, can you each quickly introduce yourselves, and then we'll continue? Maybe start with Puck.
Yeah, hi, can we hear me?
Yep.
Okay, cool. Hi, I'm Puck. I use they or he pronouns. I've been on the CRIS Lived Experience Subcommittee since we started. And yeah, since we began, I've been really concerned about first responders. And so I was really excited to join this community to explore how that all engages with the LGBTQ communities that I'm part of, and also for communities of color that I work with. So I jumped at the chance to join this subcommittee, and that's me.
Great. Thank you, Puck. Bethany?
Hello. Greetings from Salt Lake City. I'm actually at the U.S. Aging Conference, taking a break from all the sessions and presenting earlier today. So my name is Bethany Phoenix Osgood. I'm a director, tribal liaison, and EMS coordinator for Aging and Long-Term Care of Eastern Washington. I'm also a lieutenant firefighter EMT and community resource officer for Pend Oreille Fire District 2, 1, and North Spokane County. When I was offered to work on this work group, I was so delighted because there's not only in my lived experience, but I'm also on the front lines in rural, frontier, and urban with crisis response, working on the ambulance, working as a community resource officer, and then with our elders as a tribal liaison and older and disabled population. So I want to say thank you so much for this opportunity to speak with you today, to learn from you today, and your time.
All right. Thank you so much, Puck and Bethany, for both being on the work group and for helping present today. Chloe, can you go to the next slide, please? Okay. So this is just what we're going to talk about today in our short presentation. I'm going to start us off and talk about our charge and how the work group came to be. I'm going to share a list of the participants and maybe a little bit of remind folks how that group was formed, and then describe our process that we went through as a work group. And then Puck and Bethany are going to take us through kind of the outcomes or the recommendations that we developed throughout this. So yeah, next slide. So just as a reminder, and I know we mentioned this earlier, that the CRIS has been having some conversations around someone to come for a while. And back at the March CRIS meeting, March 22nd, we were having some conversations around first responders and behavioral health crisis response and collaboration. And everyone at that meeting, we acknowledged that there are circumstances when it's appropriate for first responders and behavioral health crisis response to collaborate, right? Is the system, right? That we need the two to work together often. And so we also recognize that, you know, due to systemic racism and other structural pressures, many communities face disparate consequences from law enforcement involvement in mental health situations, crisis situations, right? Including people of color, LGBTQIA+, populations, people with disabilities, and more. And these consequences can be life or death in some situations. So, and then we also know that the CRIS is charged with and committed to ensuring a behavioral health crisis response system that is equitable, fair, and just. So with all of that in mind, we developed this work group, this behavioral health crisis response and first responder work group to come together to develop recommendations for the CRIS steering committee to ensure the appropriate, effective, equitable, and safe collaboration between first responders and the crisis response system. Okay. On this slide, you'll see our charge at the top, and then in the boxes below kind of lays out our process. So we kind of started with this vision of our ideal future state is Washington has an appropriate, effective, equitable, and safe collaboration between behavioral health, crisis response, and fire, police, and emergency medical services, right, our first responders. So knowing that was our vision, we then focused on brainstormed the challenges, barriers, or fears, or what gets in the way of us achieving that vision, right? Because we know that in systems change, in order to change something, right, you need to first be able to identify what's not working or kind of what the barriers or challenges or fears are. So we started by identifying those as a group. And then once we had those developed, the work group then worked on developing recommendations to address those barriers, challenges, or fears, right? And that's what we're going to talk about today is kind of both what we identified as a work group, what those barriers or challenges were, and then the recommendations that the work group developed to address them. Okay, we did this over the course of about 4 meetings over the May and June. Okay, next slide, Chloe. So this is just a list of the folks who participated in the work group, in case folks are interested to see kind of who was there, who participated, what the representation was. So this work group was a voluntary work group, right? So after the March CRIS meeting, Nicola sent out a call for volunteers to participate in one of 2 potential groups. One was around the crisis response best practice guidelines and dispatch protocols, right? And then the other was for this behavioral health and first responder collaboration work group. And these are the folks who volunteered. And so you can kind of see we had great representation from lots of different systems, people with lived experience from different areas of the state, first responders, behavioral health crisis. So yeah, it was a really great work group, and it was these are very challenging, complex conversations, but it was a really fun work group to be a part of. I think we all learned a lot. We all really kind of, I think, connected in various ways throughout our time. All right, next slide. Because this is a systems change and some challenging conversations, we did want to set up some group norms just to kind of start out with for us to kind of make sure that we were effectively communicating with each other. And so the first 4 at the top were ones that we started our work group out with. So we wanted to just say, again, acknowledge that this is not about if first responders and mobile crisis response will collaborate, but rather how they will collaborate. We know there will be collaboration, so how to make sure it's safe, effective, right, and appropriate. Accept that structural racism and oppression exist and has life-threatening impacts on people of color and other marginalized communities. So we weren't there to debate that, whether or not structural racism existed or, whether it had negative impacts. We just accepted that and said, okay, now we need to address it and try to get, come up with ways to overcome that. We wanted to make space for multiple perspectives and experiences, make sure lots of voices emerged in the process, and then focus on our task at hand. We added 2 more after the first meeting, just recognizing just how difficult it can be. And those 2 were that this is about systems, not individuals, right? We can critique a system while still acknowledging that good people work within them, right? And have good intentions. And then we also added expect discomfort, right? Complex system change requires waiting into difficult and challenging conversations at times. And so we asked that for folks to really stick with it and stay with those engaged in those conversations. And I think this really helped us achieve our final outcomes. And with that, I think the next slide, I think Puck is going to take over from here. And so I'll hand over to Puck, and Bethany, you can finish up our presentation.
Hi, yeah. So we had a few different tactics that we took in order to make sure that this was effective. One was a breadcrumbs document where we took the ideas that everyone had brought up and we connected how those then rooted through into the further conversations of succinct, tangible, action-oriented things that we're able to recommend. There was some live on-screen note-taking. There were a relative variety of folks on the work group. That commitment to staying engaged we talked about, and that distinction between people and systems was a big one. And then at the beginning of the last CRIS meeting, you heard Chief Harding asking folks to assume positive intent. We all, I think, can get pretty tender here. And so knowing that we were all coming in trying to make things better was really important. Next slide, please. So yeah, then we've got just the first thing we came up with was that list of barriers, and then we'll go over those, and then we'll talk about the principles that kind of came out of those barriers that we saw, some underlying expectations and assumptions that we found when we talked about those barriers, and some recommendations. The full recommendations you should have in your email as well, but we're going to highlight just a few of them. Next slide. And Bethany, I don't actually have my notes, so I'm going to toss this over to you and you can send it back to me in case it's mine.
Yeah, so I'll do the slide and then Puck, you do next. We didn't get a lot of time to rehearse, but Puck and I work well together. And Michael, thank you for setting us up for success. So we really wanted to tackle what are the barriers? And we're starting with level number 1 is lack of adequate and consistent training, integrated systems, and shared understanding of those roles, responsibilities, authority, and approaches. And we would also like to add communication. Communication is key along with that training so that as we're working through a crisis, every agency knows where they can jump in, where they can offer support, provide the continuum of care. Number 2 is lack of consistent and clear processes for determining when a behavioral health crisis has an existing safety risk component that requires first responders, which can lead an inappropriate response or a level of need. So an example would be maybe calling in the police officers during a dementia crisis when it's not a behavioral health crisis, and not having that recognition of, aha, this is medical and not behavioral. And so escalating the situation in an appropriate way would not be best for the patient or the person that we're working with or their family. Lack of parity and funding for crisis systems at all system levels, which results in a 911 emergency room being the default. So good examples of that, especially in rural Washington, is transporting a person with behavioral health crisis or dementia crisis to a non-appropriate emergency room for that behavioral health bed when they don't have those in existence. So how do we communicate ahead of time to ensure that the person is being brought to the correct facility to handle the crisis with them and walk alongside? And then there's also, we talked about the lack of trust and relationships between systems and between communities, behavioral health, first responders, hospitals, ER systems. And then we also wanted to add in and have that consideration for tribes, communities of color, LGBT communities, and rural communities. So building that trust so that when we respond, that person is well taken care of with the DEI, ADA, and culturally competent lens. Pat, I'm going to throw it over to you for next slide.
So the next one is that the crisis system as it stands isn't community-centered or consumer-centered, and it's really not easy to access. There's also not a consistent or baseline level of services between all the regions. We talked about how the regionality that we have and centering regional independence is great, except for when it then lets some of the regions fall behind on what resources they have. We also talked about lack of a shared vision for co-response models in Washington, which leads to difference in standards, implementations, oversights, and outcomes. This started out as kind of even a definitional confusion, but then realized like, oh, it is because we're talking about different things, right? Then there's some concerns over consumer confidentiality and presence of body cams. Also talked about access barriers due to concerns over involvement with immigrations and customs enforcement. And then we talked about the last one here is a little more complicated, where complex social and medical needs combined with lack of resources make crisis situations even harder. It's that trouble with a social safety net that makes it hard to address things before a crisis, so then you get to crisis more quickly. Next slide, please.
Go ahead, Puck, you're on mute.
So these are the foundational principles that we found underneath those barriers. The first one is that we all want to move toward a more collaborative approach with aligned and complementary systems. We saw that a lot in talking about different barriers in collaboration through different parts of the systems. Number two, people with lived experience should be included in every aspect of this work. Number three is that this is not about if first responders and mobile crisis response will collaborate, but rather how they will collaborate. Bethany, can I toss this one back over to you?
Number four is this is a systems overhaul, not an individual overhaul. We can critique a system while still acknowledging that good people, we're all here for positive intent, like Chief Harding said, and we all want to work within the system. And then number five is ensuring that collaboration and partnership with tribes. I spoke with that before, but we need to respect their sovereignty. We have so many different recognized tribal agencies, and they're also having a 988 and a behavioral health crisis response work group. How do we communicate back and forth to ensure the continuity of care? Next slide. Recommendations and system change. We wanted to speak about leadership, resources, policies, procedures, workflows, training, and monitoring and accountability. In the essence of time, we're not going to go into a deep dive, but everybody here on the CRIS team is a leader, and you're here for system change, and you're here for communication and ensuring that as we go through the system, that your leadership really brings these points to light. And so remember that when we're making policy change, when we're doing training and implementing education across the board, that us as leaders, we need to dig into those resources. Do those policies fit the existing system as it is now? What procedures and workflows can we do to inspire that collaboration and communication? What training do we have? As a side note with training, our system is developing the very first simple platform, easy to access dementia training for first responders, which has an ADA, dementia, tribal, LGBTQ platform, which will be available across the state, and it'll be standardized for police, fire, first responders, crisis workers, 911 dispatchers. So looking at those platforms, and then how do we monitor and provide accountability that we're doing the work that we said we were going to do? Next slide, please. All right, this is you. Is this still me, Puck, with leadership? Okay, I'm going to keep going till you mod at me. So leadership, this is one of our primary change pillars. We want to advocate to lessen criminal injustice information, the CJIS laws that prevent peers to have access working with law enforcement. A good example is if you have a nonverbal behavioral health crisis patient or a nonverbal dementia patient, and their care partner does not have a POA or legal documentation, how can they advocate for that person when they're nonverbal or unable to advocate for themselves? Oftentimes those care partners have the best recommendations and know exactly what that person needs. Advocacy for policy change related to public information requests and body cam footage when there is patient confidentiality concerns. When is it appropriate to use those body cam footages? And when is it appropriate to respect that confidentiality? And then advocacy for policy change that bars immigration status to be used in behavioral health crisis response situations. Washington State is a large and diverse urban, suburban, rural, with a lot of different people from different cultures with different standards. So how do we move through those requirements while we're providing the best patient care in the moment of crisis? Next slide, please. All right, this is your Puck.
Yeah, so we talked about resources, and that one can be a little complicated in terms of, like leadership, we have some things that are within our scope and some things that aren't. But we talked about advocating for increased resources for all of the systems that support the crisis response system in order that we can ensure that the staff have living wage, adequate resources, and workforce stability with a focus on behavioral health. Some conversations about this were career paths that can kind of travel through different roles within crisis response. What if there's someone in law enforcement who wants to get into behavioral health aspect of it and vice versa, and just kind of improving that collaboration and talking about trying to figure out, you know, we are currently understaffed and how do we address that and make that less of a challenge. And then we also talked about that safety net again, funding more prevention services to avoid the need for crisis. But here prevention isn't just mental health prevention or mental health crisis prevention, it's also prevention of crisis in general. You know, how are people meeting their needs, and are they able to do that without becoming a crisis in itself? Next slide, please. And Bethany?
So we also wanted to talk about policies, convening a work group with representatives of first responders, behavioral health staff, people of color, tribes, people with lived experience. Those intersections of those identities will help frame our new policies and procedures, as well as we want to make recommendations to determine define how the assessment, safety risk, and behavioral health crisis, and for that appropriate response. The other side note, especially with the policies, is do we need to look at reimbursement rates? Reimbursement rates, not only for the EMTs and the first responders, but reimbursement rates that will support that prevention work and support that ongoing training as part of that policy, so that people will want to come to the table and we can build our workforce that are trained, empathetic, and have an understanding of what those policies are. We want to include safety that acknowledges and takes into account the racism and the bias that show that impact this policy as well. The more people that have the buy-in, the education, the prevention training, the support, and the proper reimbursement will show that empathy across the board and open up those levels of communication. Any policy decisions that should lead the development of standardized protocols and implementation. We should include identifying what data and what indicators to monitor and assess those impacts. So what we're trying to do is not only inspire those policies and procedures, but inspire those resources and funding and training for everyone, so that we're all on the same page when we're going to that crisis, so that we can treat that patient with dignity, honor, and respect. Next slide. Procedures, protocols, and workflows. Puck and I are going to go back and forth on this. I'm going to do the first part and then turn it over to Puck. It says build upon current 988 dispatch. So we need to establish a consensus on the rights of people in crisis and create a caller bill of rights. This really focuses on that informed consent for communities, develop clear materials for communities on what to expect. What do I expect when I call 911 or 988? Are they not only going to see me as a person, but I'm in crisis? Are they going to respect my cultural background and who I am and where I'm coming from? And are we going to include some sort of monitoring plan to assess those trends? Assess how do we get that prevention upstream to lessen those calls and get those crisis responses with clear collaboration and communication. All right, Puck.
Yeah, so this talks about building upon the current dispatch protocols that we've been working on in that other work group to include 911, but just kind of how we walked into this work group being like, yes, the law enforcement and first responders and the other people, we realized we were talking about 988 and 911, and oh, no, we actually need to do this through collaboration as well. We've been talking a lot about how to get buy-in from 911, but really it needs to be a collaborative process of going through dispatch protocols and finding some mutual agreement and expectation of what happens in terms of mental health call coming into 911, what happens in terms of more active crisis coming into 988. So working collaboratively to develop those and then growing those throughout both systems. The next idea that we had for systems change under procedures, protocol, workflows was the idea of maybe a pilot combination crisis response and first responder collaboration in a region that's interested in that. And then if that works out, we can look at best practices and see where we can learn and grow and how to spread that as well. Next slide, please. So this is under the training, and we talked a lot about different training things. We talked about partnering with folks with lived experience in order to create those trainings, and then requiring participation for behavioral health folks and first responders. And then points under that training would address those concerns about roles, authority, requirements, training, and approaches for both behavioral health and first responders. Looking at implicit bias and how to recognize and address when power and privilege are taking over situations. Looking at best practices for engaging with people when they appear erratic or not non-compliant. There was a lot of conversation about when people are in crisis, they aren't good at responding to things. And so how do we respond to that without escalating? Also, that's what the next one here is understanding the difference between safety issues and things that are pretty normal to see in behavioral health crisis. And then looking at culturally responsive and trauma-informed methods for interactions, person-first and respectful interactions. And then Bethany, do you want to grab that next one?
Right. So we also want to talk about expand the work happening under MHAADS that can help advise the community on educational campaigns that champion things that make the system or the client more centered, inclusive behavioral health, release of information, mental health advanced directives, and incorporating those integrated platforms. So really having the understanding, is this a behavioral health crisis? Is this a medical health crisis? And how do we support that person in crisis through those integrated platforms? Next slide, please. Monitoring and accountability. Everybody on this work group, and Puck and I both, I believe, we're agreement and on the same page, and Michael did such a great job with Nicola walking us through this. Due to the root cause of analysis and the lack of trust between systems and the community, the behavioral health and first responders, between the both systems and communities, we acknowledge that this could cause work situations or the elevation of that crisis situation. And the work, we can do this to develop those solutions. When we come to the table and we admit we need some communication, we need some common ground training, we need common ground solutions and funding, then we can work together to ensure that that crisis situation doesn't become escalated or cause patient harm. And I say patient harm, it's also client harm. I just come from it from the ambulance point of view, but it's a person harm. We want to reduce that. We also recognize that conducting an audit to ensure alignment with the current CIT training standards for co-response programs in Washington is needed. And that we will also need to really emphasize is that piece for legislation, active communication, training, education, and funding, so that we can all be on the same page for that patient-centered care. Next slide. We had some really cool thoughts in closing. I'm going to read a couple, and then I'm going to just turn it over to Puck, because she's the great closer of our work group. And it's been an honor to work with all of you. And thank you for your time. And when I read through these, reading everything made me feel like my voice was heard and I was appreciated and represented. The most satisfying part of this work was being a part of it. And I can speak for myself, the entire team, because I do come from the medical first responder aspect. They listened, they heard, they took down our education, and they saw that my personal passion for that continued funding, the continued training, and the continued collaboration, support, and communication across the state just makes our job so much easier. And at the heart of my passion is to take care of the person in crisis, no matter what it is. And so it was really, really cool that we could speak our minds. And we haven't always felt that way. And this, the times I don't speak up or I feel that there's a conflict, the CRIS work group lessened that through Michael's leadership and said, this is a safe place. And I'm going to close with that with a thank you. And I'm going to turn that over to Puck.
Yeah. So I literally started my first of these meetings at the dentist, and the meeting was less painful than the dentist, which I was dreading this process, and I feel like we were able to have good conversations and honestly discuss the fears that different communities had coming to the table. And obviously there's a lot of work to be done, and unfortunately this work group recommended creating more work groups. But as it is, I do think that we've made some good progress, and we've had a chance to question some of the assumptions that all of us had coming into it, in order to hopefully, build better systems, do less harm. A lot of these talk bubbles here talk about being heard and feeling like they made a difference, and that's true for me too. As I felt for one of the first times for me throughout this CRIS process that there's things that I can point to and say, hey, my input here is going directly into those recommendations that we made to the steering committee. And so I'm really grateful for that and for everyone else who was involved in making this happen. So that's what we've got. Like we have in chat, there's more information on this on the website, and at the next steering committee meeting, they'll have a chance to talk through and figure out what they want to do with them. So that's what we've got. Thanks so much.
Thank you so much, Puck and Bethany. That actually, Puck, your comments segue beautifully to one of our co-chairs. Bipasha is going to just say a few words, and then I'd like to open it up for questions, Q&A to our work group members. But first, Bipasha.
Can you hear me? Wait, can you hear me?
Yes, we can hear you
Okay,
beautifully. Yeah.
Okay. First, I'd like to thank every member of the work group, including the facilitators and the people who held space in so many different ways. Thank you for your hard work, patience, persistence, willingness to work through difficult and diverging perspectives and arrive at concrete, actionable ideas. It is critical to identify ways to improve coordination and collaboration between first responders and the behavioral health crisis response system if we are to really serve the community in an equitable and effective manner. The steering committee of the CRIS is charged with listening to the CRIS's input and developing recommendations for making system improvements based on what they say. I, as a member of the steering committee, along with others, I know will seriously consider and address the outcomes of this work group at our September meeting. So I want to say to the work group, thanks for grounding us in the idea that it's not an if first responders and mobile crisis teams will collaborate, but how, so that there's a good outcome for everyone in the community. The reality is that structural racism and oppression exist. We don't get to negotiate the truth of that. One thing that was mentioned that is vital, I thought, for all of us on the CRIS to be grounded in, is that we're talking about systems that are based on old, outdated, and wrong ideas. This is not about tearing down individuals working in the system. There are many, many, many good people doing good work every day. For instance, the people in these two work groups that came from diverse backgrounds and were willing to stay engaged, even when, understandably, you were upset and maybe wanted to say, this is not going to work. And honestly, for me, hearing Puck talk about the reality of needing this collaboration between the behavioral health system and first responder was very heartening, because I know how hard he fights for basic human rights in the behavioral health journey. And among the specific recommendations that jumped out for me, of course, being lived experience, that lived experience be part of every step of the process and every process. And that we shouldn't have, that behavioral health is a very wide thing. we shouldn't have to choose between housing, access to jobs, healthcare, food, clean water, transportation. All those systems are connected to good emotional well-being, which reduces behavioral health crisis. We want well-staffed, well-paid, well-cared for behavioral health workforce. So Washington really needs to invest in a multi-pronged system for better behavioral outcomes. And I'm stating the obvious that these things are complex, that they're going to require multiple efforts over time to make improvements we want to see. I love the recommendation of convening an ongoing diverse work group. Many times I think, and I think we all think, oh, we'll find an excellent solution quickly, but that's never the case. This is a challenging statewide project with so many geographies and populations. It's just going to require persistence. That's what I learned just by being part of the CRIS. And the work will need to continually evolve over time. And on behalf of the CRIS and Steering Committee, from my heart, I want to thank the work groups for getting us started. And I look forward to continued work in this space. But I'm going to end with this notion that was brought up, assuming good intent. I have to tell you, through my own lived experience, when I've been able to do that, my own mental health does better. I'm always, for example, trying to figure out, do I call my partner on his bullshit? How much of it is me having to hold myself accountable for stuff? How do we both aspire to higher standards of kindness and collaboration? I think that basic applies, of course, at a much larger scale when we're working with multiple systems and multiple partners. But I'd like to believe we can do better than we did in the past. So thank you so, so much.
Hey, Pasha, thank you for those very wise words. And I'm going to think about that a lot today as well, just in my own life. But before we go to that place, I would love to open it up to our CRIS committee members. If you have questions for Puck, Bethany, Michael, or our other members CRIS committee members who also were on that work group, this is your opportunity to ask questions. We have about 10 minutes here. So CRIS committee members, feel free to raise your hand or put it in the chat. While you're thinking about that, I just want to reiterate something we put in the chat, which is Puck and Bethany shared several of the recommendations that came out of the work group process, but it is not the complete list of recommendations. For the full report or summary on the work that work group did, CRIS committee members, you'll find it in the email that went out from Nicola last week to you to prepare for this meeting. And then I also put the link for everyone else to the HCA, the website that we have for the CRIS committee on the HCA web pages. Fortunately, it wouldn't let me copy the link directly to the report. So you'll have to scroll down and find it in the meeting materials, but it is in there. And it is, I'm just going to give you the name of it. It's called the Behavioral Health and First Responder Work Group Updates. So it's all located in there. So CRIS committee members, any questions? Representative Orwell.
One, I just want to say thank you. I just think that was such incredible work done. And in some ways, you're modeling the behavior we all need to have as we move forward of how we collaborate. I think I look forward to really reading more of your recommendations. I think the good news is that House Bill 1134 provided some framework around training and funding that can help move your vision forward. So just want to say thank you.
Thanks, Representative Orwell. And I agree with you so I learned so much from observing how this process moved forward. And I would love to bring a lot of that to our bigger group work so that we can continue in that direction. So thank you for saying that. Other CRIS committee members, any comments or questions? Well, Puck, Bethany, clearly you did a fantastic job giving everyone an overview because it was very clear it looks like it was very clear to all of our CRIS members. And as Bipasha said, the steering committee is going to start really thinking through and talking about and addressing these recommendations at the September steering committee meeting. So very much looking forward to that discussion. And then of course, we'll report back to all of you on what came out of that. If you're not able to actually observe that meeting. We are a little bit early, which is a rare treat. And so I had originally shrunk usually we do a 10-minute break, but I'd shrunk it to 5 because I was worried we'd run out of time. But I think I can give you the full 10, which I think would be appropriate since we are having our meeting over the lunch hour. So I'm going to go ahead and ask everyone to jump back on at 12:45. And please come back on, CRIS committee members, with your camera, and we'll start our discussion. Just one last huge thank you to Bethany and Puck and all of the folks who put in the time on this work group. A big thank you to Michael, who's calling in from his vacation overseas to present to you all today, and also just for facilitating such a brilliant and thoughtful and thorough process to get us to this really good place. I'll see you back on camera in 10 minutes at 12:45. Thanks, everybody. Okay, I'll give folks another couple seconds to get their cameras on, and then we'll get started again. Okay, Chloe, if you could advance the slide, please. All right, so this is the discussion portion of our agenda. And as a reminder, what we're doing is starting the process of really shaping the recommendations that we're going to be putting in the report that Betsy mentioned is due January 1st, 2024. This is our progress report. Some of the recommendations we discuss may wind up not being in that report, but maybe future recommendations, but we want to start laying the foundation for that, for those recommendations that we're going to be coming to for the end of the year report or the beginning of next year report. And this is going to be the first of a few conversations. We're going to continue with this when we get together in August, and then hopefully in person in September. So as with the last meeting, what we did was we went back and we reviewed everything that the CRIS discussed at the February, March, and April CRIS committee meetings. And so there we were focusing primarily on mobile crisis response for adults. And then at our April meeting, we talked about mobile response and stabilization services for young people. And we pulled all of that into that document that Nicola sent out to all of you on Friday, and that actually Brittany just sent again to you. So it'd be at the top of your email box. We'll also be showing this on the screen as we go, but I think it might be easier for folks to look at it locally because you can zoom in. Sometimes it's hard to fit everything on the screen and not have the text be super tiny. So what I want to do is just set up the discussion. Now I've given you kind of an overview of what we're planning on doing with this. And now I want to kind of walk you through this document that we sent out. Actually, you know what, Chloe, if you don't mind pausing the slide, I think what I'm going to do is just show the document so I can give everyone orientation to what they're going to see in here. So just as a reminder, these are your words. I also worked with Michael to incorporate the words from the work group that you just heard from. So you'll see that in here as well. This is the first page of that document, and I apologize that it probably looks very tiny on your screen. I'm going to just zoom in here. So the first column on the document documents gaps in the mobile crisis response system. And this was as identified by you all at the February, March, and April CRIS committee meetings and by the collaboration work group. I'm just going to call them the collaboration work group moving forward so that we don't say the entire long title every time. Then you'll see that the second column is progress to date on addressing gaps. We had great help from the folks at HCA who went through all of the system gaps that you provided and indicated where they saw that there might be some work that has been done to address those gaps to date. We also documented legislation that passed in this last session that might be making some progress on those gaps. And any other items here that we think might be important for all of us to track as we think about what we need to do next. Moving to the third column, this column again documents, in your words, potential future actions for state agencies and legislators. So in some of those conversations we had earlier this year, a lot of you mentioned what you'd like to see to address some of those system gaps. And so that's captured here. We've also captured what the collaboration work group said along these lines. And then HCA offered a few more food for thought for all of you. And then finally, this last column, potential opportunities for CRIS. So in addition to actions that we've talked about wanting to see the state agencies and legislators take, we're also documenting here ideas that you've all come up with that the CRIS can carry on with either this year or in our next year together. The document is, this is the overview of the columns. The document is actually divided into 5 sections. I tried to group your system gaps by kind of a topic area. So this is related to data and reporting. The next page is related to crisis dispatch. That's a pretty high level, or crisis response. The third page is about capacity and issues with the crisis response system, the mobile crisis response capacity. The fourth page is related to equity and safety. And then the fifth page, actually, sorry, the fourth, did I miss the heading here? I apologize. I think I did miss the heading here. This is about the system being difficult to navigate. So what I'm going to ask, I'm going to stop the share here. What I'm going to ask folks to do is, this did go out to you on Friday, but I recognize that maybe you didn't spend the weekend pouring through this document, and that is totally okay. What I'd like to do is go section by section, because it's just a lot to take in. And I want to give CRIS committee members a few minutes to review the section, digest what you're seeing there. And then I'd like to have our discussion about that section. And then we'll move to the subsequent section. And we'll try to get through as many as we can today. Anything that we don't get through today, we'll tackle in August. And the prompt questions that you were sent that I would like you to reflect on as you review each section. Chloe, if you could put those slides back up, I'll just remind everyone what those prompt questions are. Thank you. So we have 3. So recognizing the progress that has been made and work underway, where are system gaps remaining? So as you look at that first column of system gaps, and then you look at the progress to date, where else do we still need to do some work? And how does that align with what you're seeing in our ideas for actions for legislators and state agencies and CRIS actions? And then the second prompt question is, where can CRIS recommendations build on the progress by state agencies and the legislature rather? And then finally, where are opportunities for the CRIS to advise and support state agencies in work to implement system changes? And we're going to do that, as I said, starting with the data, that first page of the document. And then once we've had our discussion and worked through that, we'll move to the next section. I want to pause there because I think that's a lot and it might be a little confusing. So I want to make sure all CRIS committee members know what we're going to be doing and feel clear on this. CRIS committee members, does that make sense? Any questions before we dive into this? Okay, Chris, are there any CRIS committee members? If you could just raise your hand, are there any CRIS committee members who don't have access to your email and wouldn't be able to look at a local version of the document? It looks like everyone's good. I'm going to go ahead and put it up anyway, just so that our community members who are participating today can take a look at it. But in the meantime, what I'm going to invite CRIS committee members to do is take the next 7 minutes. I'll check in with you to see if you need more time, and review that first page of the document. So page 1, the one that says data and reporting, and think about those prompt questions that are on the screen. And then in 7 minutes, so that would be 1:01 p.m., we're going to come back together and start discussing what you think. Sound good? Okay, so what I'm going to do while you're doing that is I'm going to put the document back up on the screen. And then I'm going to put these prompt questions in the chat so that everybody can remember what you should be thinking about. Okay, see you in a few. Okay, I'm just checking in with CRIS members. Does anyone need more time? Just raise your hand or send me a chat if you feel like you need a few more minutes. Okay, great. So it looks like we can start talking. Let me just check the chat here. Okay. All right. So CRIS committee members, after looking at that first section on data, let's start with the first question. Recognizing the progress that has been made and work underway, what if any system gaps are remaining for you? And we're talking specifically related to data and reporting. You came up with plenty of other system gaps that are located elsewhere. So any thoughts there? All right, I see Dr. Snowden raising his hand. Dr. Snowden.
Thanks. Can you hear me okay in the speaker?
Yes, you sound great.
Okay. I think based on the presentation from the collaboration group, I'm worried that if it's not explicitly listed in the data definitions and things, that this issue around defining safety risk might get lost. And to me, that's a pretty critical, I think, thing for them to have pointed out. So I'd like to make us clear that amongst all these things that we need to be defining and standardizing, this concept of safety risk in the crisis is, I think, pretty key.
Dr. Snowden, I saw a lot of nodding heads as you said that. And actually, that does show up as a system gap later in this document. So it probably sounds like it probably belongs here as well as the location where we put it. So thank you for raising that again. And okay, yes, Senator Dingra asked if I can remove the slide so that we can see each other. I can do that. But CRIS committee members, let me know if you need to see it again. I can just pop it right back up. And then I'm seeing from Kashi in the chat, as we discussed earlier, despite progress, there is a persistent lack of data on youth callers and youth receiving mobile crisis response. So that is clearly an area where we need to do some work. We talked earlier about both being clear on our definition of youth and transitional youth or transition age youth, and also how we might overcome some of the, or address some of the barriers that we face with respect to privacy, caller privacy, and not disclosing. So thank you for that. Senator Dingra.
I have a comment outside of data, so I don't know if people wanted to continue talking about data and I can come back, but is that okay to switch topics?
Well, we're going to be going through some of the other system barriers so that it might fit better elsewhere, but I don't want to cut you off. So if you wanted to throw it out there, and then I can let you know if we need to put it in that one.
So, in the grid when we were talking about future recommendations, I really want to make sure we clarify the understanding between regional and state decision-making authority. To me, that's critical. It's not just differentiating it. Someone has to be responsible. And so I think it's imperative that when we do regional and state decision-making, that the state still has to make sure that whatever decisions are made, they are resulting in people getting services. And so that accountability to make sure those decisions result in putting people first and getting the services they need to the people, I feel that has to be captured somehow. So if the regional people make a decision and there's still barriers, we still need someone else to be able to step in and say, that decision needs to be revisited because it's not working out. And the same is true. The state makes a decision and thinks local communities taking care of something, but that resource or that infrastructure isn't there, making sure we then go back and revisit that decision making with a result-oriented approach.
And Senator Dingra, I'm taking what you're saying to be something that probably a thread that needs to be throughout this. And it can't be just compartmentalized in data or something else in here, but it's throughout this is understanding where regions have decision-making capacity, where states have decision-making capacity, and making sure that things aren't falling through the cracks and nobody is making decisions. Am I hearing that right?
That's correct. I mean, I
Okay.
had this discussion like 4 years ago when I'm in a meeting and I look around the room and I go, who's doing the care coordination? And literally everyone pointed their finger at everyone else. I think Carrie might remember that meeting. And I'm just like, I'm sorry, who's doing coordinated care or case management? And literally that was it. And I do want to make sure that we have an infrastructure set up to make sure that doesn't happen. And second, the other thing that goes along with it is, again, people can have the ability to make those decisions, but really making sure that those decisions are resulting in meaningful access. So you can make a decision about mobile crisis response, but for people who are accessing the services, if they're not seeing that, that's a decision that has to be revisited, and someone has to be able to say, sorry, revisit that decision. That, like, whatever plan that was put in place is not working for this community.
So being pretty outcomes focused, and that sounds like it's very important to mention here, in particular, since we're talking about data and reporting, how we track and then hold systems accountable. Is that accurate? Okay. Thank you for that, Senator Dhingra. Representative Orwell.
Thank you. And I strongly agree with Senator Dhingra. You know, the heart and soul of 1134 was, how do we get clinical services more rapidly to people in crisis? And, you know, Healthcare Authority will be certifying the teams. There's, you know, money to actually give enhancement rates to people that meet, you know, certain timelines. But one of the data pieces on that, which I think is really important, is that the call centers, especially as they become the 988 hubs, is really going to be kind of the check of the system of, you know, who responded, how long did it take to get there, and then sending that data to, you know, I don't know if that'll be the ASOs or if that goes directly to Healthcare Authority, but I think capturing that, because I do think the 988 hubs, especially as they begin doing more dispatch, are going to be part of that data system that gives us the view of how the teams are responding.
So not just tracking who's calling, but actually how that call is responded to, who receives mobile crisis response. Okay. And I saw Carrie nodding when you said that that data would go to the BHASOs. Did I catch that right, Carrie?
I think we probably don't know exactly how that's going to be operationalized, because we have such a close relationship with the BHASOs and the MCOs, and it's sort of is it going to pass through? Is it going to live with us, with them? And so I think even King County has really started to talk about, do they need their own sort of standalone data agreement? So really great stuff that we're talking about, Rep. Orwell, and I agree with you wholeheartedly. Someone probably in Vishal's team is talking about exactly where and how that's going to be operationalized. But I do love us keeping track of that. And Jamie, I don't have my hand raised and I don't want to step on Claudia, but I do want to just reply back to Senator Dhingra when I get a chance. Okay. Sorry, Claudia. Senator Dhingra, I was thinking, and I was putting this in the chat, but since I'm talking, we do have some existing boards that are actually from all of your legislative minds that we might be able to sit down and figure out if there are some existing oversight boards we should expand or add something to make sure that we don't get some of the things lost that you were just talking about. So Rep. Orwell, Senator Dhingra, I will talk with Jason McGill from our Medicaid Programs Division, and we can maybe come up with a list of the different boards that really give the region and the state an opportunity to sit down and talk about decisions, and see if that's something that makes sense to this group.
Thanks, Carrie, and thank you for replying to that. Claudia, do you still have a, yeah.
Yes. Yeah, I know I have brought this up before, but I think that data available in terms of language barriers, you know, how many people are calling to the mobile crisis who require an interpreter? What are the different languages that we have? Is there a language that was not available? I don't think that the data comes up all the time. A very easy way for us to review it most of the time comes when it's requested. So I think have that data available so we can make decisions of who we hire, who should be in those mobile crisis team, depending on the type of population that's being served. So I think that that would be really good to have that available.
Not just offering data and translation and interpretation, but also capturing the languages and the frequency with which those are requested so that we can make sure we're staffing appropriately. Is that right, Claudia? Okay.
Correct, thanks.
Thank you. Dylan.
And also just to be able to talk about the gap of the people that end up not accessing these services due to the barriers of just even requesting an interpreter. And I think we find this a lot where working at ACRS is that people end up not accessing services because of just their experiences in the past of not being able to do that so smoothly.
So Dylan, I want to make sure I'm tracking, because I think the point you're making is super important. Are you saying we need to find a way to estimate how many people are not actually who need help but aren't actually following through because of the language barrier, or are we?
Well, I think estimating would be quite difficult, but I guess acknowledging that there is a very probable gap in those that might normally act or might benefit from these types of services, but are not accessing it because of the barriers of accessing care.
Okay. Okay. Thank you for that clarification. And I am seeing actually a related question from Puck. They're saying, how can we measure the people who go through crisis but don't engage with the system? So the who are we missing question. And Dylan's raising the specific point of that the barrier could be language. But I think we've also talked about some of the other barriers that come up for people that are going through crisis and not accessing the system. I know the collaboration work group talked a lot about, and we actually have a whole section in this document about the specific barrier of people of color, LGBTQI plus, people who identify as LGBTQI plus, the fears that they have with engaging with the system. Okay, I'm going to pause for a second because we have a bunch of comments in here in the chat from Bipasha. How do we tap into user input in addition to looking at other data? So Bipasha, I'd love to probe that a little more with you if you're willing to, you can put it in the chat or we can talk about it. Tell me a little more about what you mean by user input there, if you don't mind.
I think it's like in customer service, right? You measure what your customer is experiencing in accessing a service. Retail does that, business does that. So why can't we have a way, in addition to and many other data points, have the users have the ability to comment, critique, or rate the system based on their use?
I see. So we can make system improvements also based on how the user is experiencing it, and maybe also track some of those outcomes that Senator Dingro was talking about. Nice. Okay. Dylan, I'm sorry. I think I maybe didn't let you finish there. I apologize. Did you have other thoughts you wanted to throw in there?
I mean, it was actually just circling back to one of the other who was speaking, but around other work groups and that might be existing. I can't remember if this was brought up, but OSPI and being able to talk to or around work for the school-based providers. I can just think of so many different instances where a school provider reached out to a community-based organization where we're trying to handle a situation. They might not be already engaged with services. So it was just coming to mind. I wanted to flag OSPI, the youth suicide prevention, intervention, and postvention folks. OSPI is I forgot what it stands for.
Office of the Superintendent of Public Instruction. Yeah,
that one, the one around schools.
And that is, I understand from Kashi's presentation a few months ago, a really key entry point for a lot of youth. So thank you for raising that. All right, I see we've gotten through hands in chat. So I think let's talk about the second question here, which is, where can CRIS recommendations build on the, where can CRIS recommendations build on the progress by state agencies and the legislature? So you've looked in that recommendations column. Anything that you want to add to that, or anything that you think maybe we didn't capture quite right and you want to modify it? sounds like we still probably need to address some of the additional reporting and outcomes measuring that we want to capture that we talked about today, and address Claudia's point about capturing numbers related to what languages are requested in translation, and start giving some thought to how we track or how we figure out who's not reaching out because of different barriers when they are in crisis. So one of the things that we can do if you don't necessarily have thoughts on recommendations today is put a pin in those and circle back when we get back together about how we might start tackling those issues.
Yeah, no, just quick comment. I was wondering, the same way that we require the reporting of how long it takes to do a crisis response, 5 hours, 7, those are requirement in terms of as you do mobile crisis, you need to respond, you need to report what's the time it takes you from the beginning to the end, and should be a requirement to say, the data reporting of people who access the system, who requires who has a language barriers, what are the language that being requested, and then we can see if the language are not being requested is because we don't have it, or if there are members in the community that speak that specific language but they're not accessing the crisis system. So I think it's a lot of more that we can infer or talk a little bit more if we had the initial reporting of those as a requirement. I think that's, as we require others, there should be requirements in terms of who are we serving.
Okay, so one of the recommendations would be adding some of these requirements for collecting and reporting these data, like language and translation, so that we can even set some targets and start seeing where we might be missing those. Is that right, Claudia? Okay, very nice. Did I see Kashi raise your hand or no? Okay. Any other thoughts? So these recommendations here sounds like capture a lot of what you wanted to address. Bipasha.
I think the model that comes to mind is the model of census data collection. When you collect census data, you go out into the communities to collect the data. I think if we are going to get especially data on why people are not using the system, to get out into the grassroots organizations that really do the grassroots work. And we need people to get out there and talk to those communities. I mean, I feel even in the CRIS process, we have a lived experience subcommittee meeting, we expect people to come to us. I still haven't figured out how do we get to those communities and talk to them. And I think, so, in census, you go to every part of the country to collect data. I think that's a model that's worth pursuing.
So tactically, as we think about how we would start to uncover who is not accessing the system when they are in crisis and why, Bipasha is recommending that we take an approach that actually goes to communities and community-based organizations rather than asking them to come to us. Okay, that's a great recommendation. Thank you. Kashi.
I really do have my hand up this time. I put it up and took it down, and then what Bipasha said made me feel more confident about saying this. So I think one of the things that comes to mind in terms of where we might be able to build on progress is in the spirit of going and getting data that is not sort of being provided to us or standardly reported. I'm thinking about the continuous process improvement cycle and the plan, do, check, act cycle, where you put something in place and then you have to see if it works, right? I think part of my zoom out question is the check and act step of a continuous improvement cycle currently within the scope of the CRIS committee's work, or currently built into any process about implementing changes? And if it is, and I apologize, but I'm just thinking about, what is the accountability of this group to continue to look at data after these changes have been implemented and after, we've checked 2 months out to make sure that this works? What's the accountability to check 6 months out or a year out? And maybe we need to make some recommendations on continuous process improvement. And that's quantitative and qualitative data gathering so that we're not just, not that our data isn't great, but not we're just relying on what we're reporting or gathering, but that we're actually really going out and talking to community, people who've used 988, who've used mobile crisis, providers who've tried to refer this way. And maybe this is massively out of scope and you're welcome to tell me to direct it somewhere else.
Well, Kashi, it's funny, when I was listening to you, I was first tracking your point to mean that overall, each step in the system should be incorporating this process of evaluating and then course correcting as needed. But then you mentioned, is this within the scope of the CRIS? So I'm wondering, is your recommendation, is it limited to the CRIS's role, or is it possible that this recommendation could be structured to be an expectation throughout the system?
I think it could be both. I don't know that I have a concrete recommendation other than to say that this work does not stop at implementation. And how do we have continuous evaluation, accountability, additional data collection, community input once the work has been implemented, and whether or not that lives with CRIS is less important to me than that it happens somewhere.
Okay,
So
that's great.
Jamie, let me pop in here. So Kashi, this is part of the scope of the CRIS, and it's work that we will be doing in 2024. So you are really teeing us up for a lot of good work next year, making recommendations about the ongoing oversight of the system, as well as goals and what we're tracking and how we're determining success is a lot of the work that we'll be doing next year. So just so that everyone is clear about that.
Thanks for jumping in there, Betsy. That's actually a great reminder of what our overall work plan is and how that ties to Kashi's recommendation. Any other thoughts here on, in particular, the column around, and I just want to remind folks, this is just CRIS committee members. I've seen a couple of hands from some of our community members, and I so appreciate you being here. I'm sorry that I can't include you in this discussion, but today is just CRIS committee members dialoguing about this. That said, community members, if you have some thoughts on this, I would welcome your participation in the public comment period at the end of the meeting. So please send a message to Brittany Thompson via chat if you'd like to make a public comment at the end of the meeting. And I'll also, when I get a little pause, put the email address for the CRIS committee email box in the chat so you can send a written comment if you have feedback as well. And they do read those and they do think about them. So thank you so much, folks. Okay, so CRIS committee members, anything else on the second question about where your recommendations can build on the progress by state agencies in the legislature? Oh, thank you, Brittany. Brittany put that email in the chat there. So let's move on to the third question here. Where are there opportunities for the CRIS to advise and support state agencies in work to implement system changes? So that fourth column, we did touch a little bit on that. Kashi's comment touched a little bit on that about how we tackle, actually touched a lot on that question about how we tackle accountability. Anything else that CRIS committee members want to add there before we move on to the next section? Dr. Snowden.
Thanks. I believe that we'll define the core components of the outreach on this, but I think for implementation, we need to know more about the availability and the numbers. And so I get concerned that if we don't have adequate numbers of mobile crisis response teams, all the definitions and all that won't mean a whole lot. So at some point, I think we have to go beyond defining the thing to actually talking about how much of it do we need.
Thanks, Dr. Snowden. So I want to make sure I'm following you correctly. So you're seeing in here us advising on definitions so that we know what we're measuring and we're comparing apples to apples. But you're also saying in order for us to tee up some of this other work that we want to do, we need to actually have some numbers and a clearer sense of gaps. Am I tracking you correctly?
Yes.
Okay, awesome. Thank you. Any other thoughts on this section, folks? And I want to offer you the opportunity also, if you're thinking about it and you're looking at this document in a few days and you think, you know, I wish I had thought of this or I had said that, we're going to continue iterating on this. This is going to be a tool, as I said, for us laying the foundation for our recommendations that are going to go not just in the 2024 progress report, but also future things that we're going to tackle together as a committee. So please don't feel like this is the last conversation we're going to be having about this particular topic. There are going to be other opportunities to continue iterating on this. All right, so let's move on to the next section here. Page 2. I called it dispatch. I'm not sure that's quite the right heading term, but I was struggling to come up with something that exactly captured it. So please forgive me if it's misleading. I'm going to put it back on the screen here. All right, so I'm going to invite CRIS committee members. Let's take another 7 minutes to review this section. This is page 2 of your document. It's the same layout as the previous document, same prompt questions. And then we'll come back together at 1:34. Actually, 1:34 to discuss. So go ahead and dive into this one, please. Okay, CRIS committee members, does anyone need a little more time to digest this section? Just raise your hand or send me a chat if you need a minute or two more. Okay, so let's start with that first question for this page. Are there any system gaps that remain considering the progress that's been made to date? Anything that you think needs to be included in here that hasn't been included yet? Dr. Snowden.
Thanks. As a geriatric psychiatrist, one of the things that I really liked about the collaboration work group's presentation is that they made several mentions to the needs of people with dementia. And so I would love to see us balance the focus that I see in this whole section on youth and the needs for youth with the other end of the age spectrum in terms of older adults, particularly families suffering with crises related to dementia, because I think the needs are really very different.
I noticed that same thing, Dr. Snowden, in the presentation. It was actually, I think, the first time during this CRIS process that I'd heard mentions of dementia with respect to the process of sending out help. So thank you so much for raising that. And I apologize, Senator Dinger. I'm going to stop the share now so that we can all see each other. So thank you for mentioning that. And that sounds like something we should work on together moving forward. Other thoughts, CRIS committee members? Betsy made a note that one of the other recommendations coming out of the collaboration work group was to address handoffs between 988 and 911, and that should also be added here. So actually probably to column 4.
Jamie, we can just drop in the specific recommendation from the work group later, but I just wanted to flag it.
No, I appreciate you doing that. Thank you.
Yeah, it was a recognition that there are dispatch protocols that address 988, but not so much between, with 988 and 911.
Yeah, no, that's a great catch. Dylan.
Hey, and this is reminding us that we also don't have our ASL interpreters available today. This is something that I've experienced myself with family members trying to access emergency services and not being able to have an interpreter available. Or the EMF folks being insistent that it's not important to have that, or because it's just too difficult to access an ASL interpreter. So the idea of being inclusive of all different types of ability, language needs and age needs and diagnosis.
So the remaining system gap is that not every service that does the response can accommodates those different.
Yeah, they're just not going to be equipped for all of the situations, and none of us are ever going to be able to be equipped for all of them. But they're, deaf and hard of hearing folks are a lot more common than I think a lot of people. Nice.
Well, I'm just again reflecting on the points that Claudia made on the previous document about the more we understand where those needs are and where we're falling short, the more we can start to invest and address them. So thank you for raising the parallel point at this stage of the process. Joan.
Hi, everyone. This is Joan with the Washington Council for Behavioral Health. I apologize for not being on video with all of you today. I'm not sure if this is the right section for it, but it might be worth calling out somewhere that 1134 has a new 988 geolocation committee that was created, and recommendations coming out of that committee might affect sort of protocols for dispatch as well.
That is an excellent point, and we can add that to the progress column. Thank you so much for that reminder, Joan. Okay, other system gaps you want to note here? I just want to acknowledge we sort of made a decision to do this section by section as opposed to all at once, just because we were concerned it was a lot to digest. You've actually done a tremendous amount of work as a committee over the past few months, and this is capturing a lot of that. I recognize that does mean that we may be talking about some things that actually show up later, and that is awkward, but I'm hoping as we iterate through this process, it'll start to feel more like a whole systems approach as opposed to this piecemeal section by section approach. How about the second question we're tackling, which is where can CRIS recommendations build on the progress made by state agencies in the legislature? Are there other places, other recommendations that you'd like to add to what we've put in here, particularly for actions by state agencies in the legislature? Does this feel pretty complete to folks for now? Dylan.
I know we spoke about it in the past, and I've listed here on developing or determining who's the lead in the field. I still feel, I'm not sure if there's a lot more detail somewhere else, but how do we determine who, like, what's the threshold that we're, because that each party, maybe law enforcement or EMS or the behavioral health person, might have a different threshold of what the safety issues might be.
So Dylan, what I'm hearing you say is what's written here may not be complete enough, and you're wondering also maybe how because we're talking about different partners with maybe different metrics or standards, how we align those so that we're all working from the same sheet of music when we're going out to respond.
Yes.
Okay.
Yes. Yeah, that'd be great, because I just know in the mental health field, and I'm working with someone else in the same practice as me, who might have a very different understanding, and we're not doing anyone any favors by tripping over ourselves.
That is an excellent point. Then we can add to that. Thank you for that. See, in the chat, I'm hearing from Puck, I'm concerned about disabled communities not being able to benefit from mainstream systems. So Puck, I'm taking that as a systems gap that you're observing here that we probably need to add to this is how do these structures that we're creating, or do these structures, are they able to support disabled communities? Dr. Stone raised the point about not addressing people with dementia, and I'm taking your point, Puck, to be that it's other folks who are living with disabilities as well. Am I tracking that correctly? Other thoughts here on recommendations, particularly for actions for state agencies in the legislature? I might frame the question a little bit differently. Is this, are you all feeling like you're seeing your words in here? Are you feeling like, I was reflecting on Puck's comments in the presentation earlier about being able to see in concrete ways the work that they were doing on this work group translating to recommendations. So as you walk away from this, as you process this information and think about it, I also want you to think about, is this reflecting the discussions that you've participated in as a CRIS member? Are there things that have gotten lost here or that you feel like are missing? And we can revisit this and continue to iterate until we're at that place where you're seeing it reflect the work that you've done here. How about that last question about opportunities for the CRIS to advise and support state agencies in working to implement systems change? Anything there you want to add? I'll just remind you, this is the spot where Betsy suggested we add the work group to address the 988, the 911 988 handoff. Okay, I'm doing a time check here. We have 17 minutes. Brittany, have we gotten anyone signing up for public comment?
No, we have not.
Okay, I think I might just buy us a little more time to keep doing our discussion then. So why don't we move on to section 3, which is related to capacity. And we have had a lot of conversations about capacity here. So I'm going to share the screen again. And let's go till 1:50, and then we'll try to get as much discussion in as we can, but don't worry, we'll talk more when we get together in August. Okay, do any CRIS committee members need more time on this page? It's like you're all. Just raise your hand if you need a minute, another minute or two. Okay, stop the share here. All right, so while you're thinking, why don't we just, since we only have 10 minutes left, why don't we just take all the questions together? So please raise your hand or put in the chat if you are observing any systems gaps that we need to add, keeping in mind the progress that has been made to date. If there are additional recommendations that we could make to augment or support the progress that state agencies and legislators have made, what the legislature has made, and then finally, what can the CRIS contribute here? And I see a note in the chat from Puck. They're saying, I worry, and this is related, I believe, to the House Bill 1134, creating an endorsement of mobile crisis response teams that make them eligible for enhanced payments if they meet response time metrics. Puck makes the point, I worry about a focus on response times for pay incentives could lead to organizations unintentionally prioritizing speed over the best possible care. So that sounds like a system gap that we should note, and possibly an area where we could do some additional refining to help avoid those kinds of unintentional consequences. Dylan.
Yeah, in response to Puck's question, comment, it may be similar to how we have this pay for performance. I'm not sure about I'm just only aware of the King County system, pay for performance, and the metric of that response time for when a referral comes through. I know similar challenges have been expressed in the past. And the other piece I just don't know a lot about is this multi-state compact for the mental health counselors. And one of my concerns there is I know staff retention at some of our organizations has been a really, really big challenge for, for folks working in the community mental health. And I'm not sure how we can either make it more enticing for those in-state applicants working in these positions, or have something else in place there. Because I think there's a huge benefit, not just for the licensure, but having folks who are familiar with the local benefits and systems that can really fully support the folks that are living and working in Washington State.
Those are great points, Dylan. And I see Representative Orwell raising your hand. I know Representative Orwell was very involved in all this legislation. So I don't know if you have some thoughts on that, but please go ahead.
Yeah, it's an important conversation, and I think we probably need to continue it. And I think the thought behind the response is that for that small percentage of calls that don't get resolved on 90 days, I hear 5%, maybe that's more, maybe that grows in time, is that if we don't have a rapid response, we pretty much have a police-driven system, right? Because then it will be police. So I think the intent is to have a clinical response, but recognizing, especially in urban areas, that if it isn't within a certain amount of time, it will be by default the police. And so that's kind of the tension there. But, if there's better ways of approaching it, a lot of the crisis teams take an hour, 2 hours, it's just not the response time that would allow an alternative. The other thing I'd say on 1134 is I know it had a lot of language around specialized training, and I'm assuming, you guys will look at that too, to make sure that the list is comprehensive as far as populations we're working with.
Thanks, Representative Orwell, for offering that perspective on the thinking behind the legislation. Dylan, I'm curious, you mentioned that you are observing the performance pay issues, some of those in King County. Has anyone, have there been any discussions maybe on how to avoid unintended consequences with these approaches? Have you observed anything like that?
I know I don't have anything right in front of me, but Claudia maybe has some more insight on that. I've just heard from providers, because again, prioritizing speed over quality, and sometimes speed means quality, but they're not always the same thing.
Okay, great. So it sounds like this is something we should add as a system gap, and maybe think about some ways we can The question was framed intentionally. Where can CRIS recommendations build on the progress by state agencies and the legislature? So this is a way maybe we can build on the progress of getting some of these metrics in place or approaches in place, and then working on them and tweaking them and fine tuning them so that they achieve the outcomes we want to achieve without creating unintended consequences. So thank you for raising those. Other thoughts here, either on system gaps, how we might build on the progress with different or new recommendations, and thoughts on what the CRIS could do here. I'll give you another few seconds to think about it. I don't want to cut anyone off, and then looking at the time, I'm thinking we could wrap things up momentarily. Pasha.
I was just thinking of what a lot of people have said. I've noticed over the time that I've worked in the system is that it has a lot to do with staffing. When staffing is short, people will do what they need to do to meet those goals. So then you consider staffing. Okay, staffing, guess what? Funding, because you have to pay people to staff, to be staffed well enough. And then if you pay people enough, then you need to also make sure they're not burned out, because like I've said repeatedly, being paid enough doesn't make you a person that suddenly has 40 hours in a day. Just not going to, and excessive amount of energy. So we can see how so many things are linked, but I think it comes down to staffing. And then you don't want staff who are not properly trained and are not able to handle, crisis situations. So a lot of those systems intertwine very delicately. But I do think if you want to say one thing, it'll be staffing. Of course, then there's quality of staff and all of that, but it is staffing which leads to taking shortcuts, basically.
So, Bipash, I'm hearing you say that when we have a substantial gap in staff capacity, that's when a lot of these other system gaps become kind of rear their ugly heads. If we can tackle that staffing capacity piece, we still need to make sure that people are trained, and to Dylan's earlier point, that they're invested, they understand the local community, and they stay. But I hear what you're saying, and like the hierarchy of needs, it's meeting that staffing piece. Am I catching that right? Okay, thanks for mentioning that. It's 1:57. If there are any final comments, just raise your hand. Otherwise, I think I'll wrap this up and we'll just do action items and next steps. Yes, Marie, did you raise your hand? Oh, sorry. I thought I saw you waving your hand. All right, folks. Well, let's move into action items and next steps. Action items here are, we are going to synthesize what you talked about today and add it to this document. This is a living tool that we're going to use to continue refining until we get to our September meeting, when we're going to actually start building out what goes into what goes to the steering committee to consider for the 2024 progress report recommendations. And we'll also in August tackle the last two sections that we didn't get to today, but I'll leave some time to revisit the first three sections if other things come to mind for you. Community members will work on getting this document available to you to see. It's a living document, so we're kind of just figuring out how to make sure that you have the latest and greatest. And then the last action item I wanted to mention is we are, as I said earlier in this discussion today, going to send out that survey. It's going to look exactly the same as it did last month. We're really looking for feedback from all of you, so we can in the continuous process improvement approach of continuing to improve how we facilitate these meetings and how we support this group in collaborating and tackling these system gaps and problems as a group. So please look out for that. I think actually Brittany might put the link in the chat if you feel like doing it right now while it's top of mind, but we'll also email it out to you so you can do it at your convenience if now is not a good time. Last thing I want to say is just again, a huge thank you to the folks who participated on the collaboration work group and brought us such great actionable recommendations and some really good ideas and approaches for having a thoughtful process and a thoughtful way of tackling really difficult conversations. A big thank you to our CRIS members for continuing to persist and work and roll up your sleeves. And you know, it's actually really, I'm delighted to read the progress to date because I feel like you're all making really meaningful progress on this work. And then finally, again, a big thank you to our community members and guests, and in particular, the people with lived experience, like Heather today, who also persist and share your stories and are vulnerable. And it means a lot to all of us. Wishing you all a lovely summer. It's almost perfect weather here in Seattle, the best it can possibly be. So please enjoy it. And we'll see you in August. Take care, everyone.